Okay, great. We're going to commence the afternoon session here. Ultimate kind of case presentations, I guess, in left atrial appendage, so we're in for an exciting ride. Our first speaker, are you up first? The speaker lists are a little bit off.
I gave one talk, and the second talk is somebody gave up, so Paul asked me to give a talk on a short notice, and I'll do it, and he said, talk anything about left atrial appendage. So I said, okay, I'm an imager, so maybe I'll share a little bit of points, tips on how to do left atrial appendage imaging, if that's okay. Okay, so this is, but it has something to do with which device to choose. So these are my disclosures, and then again, I'll start with presentation. 76-year-old man with atrial fibrillation, hypertension, prior stroke, and also has a chronic headache. You will see why that is interesting. So these are the patient's concern. He says, I have to take NSAIDs for daily headache, and I'm not willing to stop them. So I guess, there are interesting things that you can hear from patients. And he says he's also concerned over the cost of anticoagulation. So it seems reasonable to refer him to evaluate for left atrial appendage closure. And then we checked his CHA2DS2-VASc score. It's 6, so which means about 10% chance, annual chance of embolic stroke. And then has bled, also very high, 4 points. So he has a high bleeding risk and high embolic risk, so it seems that it's reasonable to refer him for transcatheter closure of left atrial appendage. So these are now for him, these are the left damage. We can have a pre-procedural imaging and can have intra-procedural imaging, which of course we do in many instances. In my institution historically, and probably at your institution, many institutions around the country, it was typically pre-procedural TE and then intra-procedural TE. And then in this case, says patient, I'm not willing to have a TE done twice. So choose whichever you want, one of that before or after. So if this patient decided to have a TE, this, of course, we would have done, as we said, 4 angles, 45 degrees apart. And it's my understanding that it was Pam Douglas from Duke University. She was a key for the original Watchman trials who actually popularized these 4 angles. Just to give you a perspective, when I was a fellow, nobody has ever done 135 that I know of. It was really somewhere between 40 and 60 degrees, and then we learned these angles. But a few weeks ago, I went and gave a grand rounds at Mayo Clinic, and one person at Mayo Clinic was not very happy and said that that person might have been the first to, maybe it came up, but I know that Pamela, she popularized it. And then essentially, it was very nice that she actually came up with these 4 angles, or that we adopted as a 4 angle. But the problem is, once you divide something by an angle, it's not actually describes what's in the image. And that's what Nadira and I beautifully pointed out. Essentially, we should label these. And essentially, this is how the 45 should be aortic valve view, a 90 mitral valve view, and a PA view. Essentially, with that, what you nicely pointed out as a map, which nicely aligns if you have it in 3D ICE. But be as it may, and also then if you want to speak the same language as fluoroscopist, then you know that a 45 degrees is equivalent to areocranial view, and 135 is areocaudal or favored fluoroscopic view for interventionalists. So now we said that pre-procedural, he said he opted we found out that he had the CT for recent AF ablation, so essentially told us that he can have only intraprocedural TE, and we can now do CT. And then often these people ask me, what is the protocol for acquisition? So if you want to know how to acquire CT, these are all the elements of CT acquisition for left atrial appendage and pulmonary veins. So now he goes for pre-procedural CT evaluation. And what can I find on a CT? What are the advantages of CT over other imaging modality? And I would say there are 3 of them. One, there is CT provides a big picture of left atrial appendage and its surroundings, which often T is a really small window. We don't know what's about. And I'll show you, and actually you might ask you a couple of questions, and then you'll see how good you do. So then we can actually simulate areocranial and caudal views, which are fluoroscopic views, and then, as I pointed out earlier, we can do virtual TE. So let's look at this big picture. So you can really see all this is AP view. You can see exactly what the relationship of left atrial appendage to the pulmonary veins, the pulmonary artery, left circumflex artery, and all other relevant structures. And then We can zoom it, and it clearly shows that it's multiple pectinate muscles. And now we can also then start thinking as a CT, what is the ariocaudal, what's ariocranial view? So now if I play this, it's essentially equivalent to ariocranial. And then if you turn it around, it's ariocaudal, which you know that's ariocaudal of 135 is the long axis of left atrial appendage, and 45 or ariocranial is the short axis of the appendage in many instances. And then if you can look at this is ariocranial and ariocaudal view from a CT and then fluoroscopy. But if you're an echocardiographer, maybe these images would be more likely to show you how you typically see. This will be a 3D rendering of CT to look like TE images. So now I can ask you, so now, where is the patient head in this image? So if you know, I see it's a patient head is all the way to the right of the screen. Huh? It's actually to the right. Yeah, see, you pointed to the down. That's exactly what everybody thinks. Huh? But it's not, because we learn TE images, which is sort of like non-anatomically said. Okay? So it's a good to ask. How about this question? So this is ario view. So which pulmonary vein is marked by the asterisk? Anybody? 50% chance. Are they left-sided or right-sided? Left-sided, huh? Left upper. Your final answer?
Looks like lower.
Okay. So it's not easy, huh? Okay. So when I think. So now we can, and the third element, you can have a CT derived, which I showed in the prior case. So again, 4 angles, 4 canonical angles, 0, 45, 90, 135. Once I gave a talk and I says canonical angle, somebody objected from the audiences that I'm using Christian terminology. I says with my name. It's an interesting observation. So you can get all the angles, and here we've cited it for one particular device, and also you can have a 3D unfast view, and essentially almost circular appearance of the left atrial appendage. And then measurements of CT are 1 to 2 millimeter larger than the left atrial appendage. And then here, where is the patient's head in this image? So these are the 4 choices, 25% chance to be right by statistics alone. Anybody? It's not easy, huh? So, okay. In front, there is a little man on 3 Mensio. If you want to be fancy, you call it homunculus. Huh? Little, okay? So that this is really a representation. And then we intraprocedural TE, very similar measurements. So the question is, can we do the opposite? So I showed you how CT can emulate TE images, but can we do the opposite? Can TE emulate CT images? Okay? And this is the typical representation of 3D left atrial appendage in my lab. So we put the left atrial appendage in the middle. Mitral valve is about 5 o'clock, pulmonary artery at 11 o'clock, and left upper pulmonary vein about 8, 9 o'clock. And the reason why we chose it, because it's actually just one tilt left from the surgeon's view of the mitral valve. And then we can render it differently. And then if you make more transparency, you can actually see the long axis underneath of the left atrial appendage. And then why I'm putting this, so this is 45 and 135 degree, ariocranial and ariocaudal view of the left atrial appendage. And then this is 135, yes, so this is really 3D, as I showed you how to do that, and we rotate counterclockwise into left atrial appendage and see transverse sinus, pulmonary artery, and all the relevant, and essentially then exactly the same as the fluoroscopic image. And as I pointed out, we have several papers, but maybe I could show you how to do. Is that okay for, how we do this? So my colleague Ellen Weinrib and I wrote a couple of papers. He's really taught me so much. He's my younger colleague. He's exceptionally talented multimodality imager, so he taught me CT in a lot, and it's very fantastic, so it's absolute pleasure. So this is what we came. So we came with the left atrial appendage, a LAAM procedure. Okay, so this is, you can look at this video on the website of the journal, but I'll go step by step how to do this. So the step 1, you obtain 3D zoom of left atrial appendage is 45 degrees, okay? And I showed you how to represent this left atrial appendage, unfast view, left upper pulmonary vein at 9 o'clock, mitral valve 5 o'clock, pulmonary artery around noon, okay? And so you pectinate muscles. So in the next step, as you see, this is 130, this is 45, and the intermediate angles are 0 and 95. So now you know all the orientations from 2D to 3D cutting planes. And now in the next, you go to multi-view and this layout. And then you see this, if you look at this, if you never pay attention, essentially the image on the right by default will be the short axis view, will actually be the blue plane. Okay, so that will be by default. But instead, if you just choose, red plane, look, if you choose the red plane, now you actually have a long axis and actually look exactly like a 135. And then all what you do, then you just uncrop this image, which is you are doing this, uncropping, and then you'll end up with a beautiful left atrial appendage. Huh? So it's a very like a 4 or 5 steps, and you can really do all of that. It looks nice. Okay, it's counterclockwise to ariocaudal view, and then we speak the same language. Okay, so the question is, can we predict LA closure device location from 3D CT? And you address FIOPS. This is really the software you send them CT data, and they do all processing and can predict what kind of device. So we're considering ambular device, and this again, you can emulate ariocaudal, and then, as I pointed out earlier, you know, there are 8 sizes, and then we decided how they differ in the size of the disc, as well as whether you use 12 or 14 French size. But then this is what you get from them. Okay, I says, you know, this is my appendage, what device you get, and you get 5 choices. So statistically, you have a 1 out of 8, they have at least 3 sizes, which is a lot of, you know, difficult ultimately, you know, but it's sort of helpful. But is that correct? They always get you, Nadira, that gives you several choices of devices. So 20, 22, 25. So outcome, we put a successful 22. And then you see this is unfast view, left atrial appendage, again, the same orientation. But then essentially, if you pay attention, there is a figure of 8. Huh? You see the figure of 8, and that's figure of 8. And that's characteristic of all Implant devices. That's whether it's a ASD closure, PFO closure, anyone. And the reason why I called when we started doing these amulets, one night I got a panicked call from one cardiologist in an outlying hospital. He says, something's wrong with the device, something's wrong with the device. There is some strange number 8 on it, must be something folded on the device. So then I says, maybe, you know, I should say that this is a figure of 8. And our colleagues from MGH, I believe, they published a paper why if you actually see it, if your ultrasound has to be exactly perpendicular to the device. If you just rotate the probe a little bit, you will lose it. So, and this is how it is. So I hope you enjoyed these little tips about imaging 3D of the left atrial appendage. Thank you.
Any questions from the audience? So, Muhammed, what is your routine pre-screening for LA closure now at your institution?
So, if there is if the patient had prior atrial fibrillation ablation, if they had a CT, even might be a 1 or 2 year old CT, we will use that to use all these methods to size the appendage. Otherwise, we will do it intraprocedurally with a TE. We will not do dedicated pre-procedural TE. We'll do intraprocedural TE.
Patients on the table.
See, the patient is on the table. And I would say maybe, but one element that I really don't like still about the measurement, because, and I will try to compare to TAVR. When we started TAVR 15 years ago, we sized the valve based on the linear diameter of the annulus. And that was not always successful. Once we switched to sizing TAVR valves by perimeter or area, we became much more successful. And I think now with the TE, MPR, we can really have the same parameters. But unfortunately, companies have not come up with the sizing their devices based. And I think we would be much better off if we had, because we'll take into account ovoid appendages and something like that.
And then what about what is your time point for imaging after 6 weeks, 3 months?
It's a typically TE. It's a typically TE unless the patient has hostile esophagus, then going to be a TE. And sometimes maybe if there is also already leaks, we will do CTs.
Yeah, I think your points about using area-derived diameter, perimeter, or average-derived diameter are exactly on point, and that was our evolution at our hospital as well. As an interventional cardiologist, I recognize early days of TAVR, Partner 1, we had an echocardiographer in the room. We were making the decision on the placement of the device, the size of the device, very much based on two-dimensional imaging, and the leak was the pitfall. That was the Achilles heel that resulted in recurrent admissions for heart failure. The left atrial appendage is seldom circular. It's most often elliptical or irregularly shaped. So if we're measuring only one-dimensional diameter, we're going to choose an inappropriate sized device. We're going to have leak.
Or, I've seen with many reps, they sort of, through experience, when they have ovoid, they sort of try to find some sort of average diameter that from experience, but it's not good. I mean, I would absolutely agree with you. It should be area or perimeter, something like that.
I have a question. The recommendation is oversizing between 8-9% up to 30%. And given the era we are right now, we are more successful, and now our success rate is defined as 0 PDL. That's what we want. Do you think that oversizing more leads to less PDLs or no?
So it's my understanding that even in industry, general, there is a tendency to oversize, to go one size up, often from the measurements. I mean, that's at my institution, that's really often is going, if there is a choice between 1 and 2 devices, if they overlap, the choice would be for a larger device. I don't know, anybody else?
Okay, we're going to keep things going here. Our next presentation is left atrial appendage closure thrombosis management with Vivian Ng.
Okay, so this talk is going to be a little bit interactive with both the audience as well as our panel here. So our patient, she was 79 years old. She has a history of atrial fibrillation, and she came in with syncope. And as part of her syncope evaluation, she had an MRI, and that had demonstrated that she likely had chronic subacute cardioembolic strokes, but probably not the cause of her mechanical falls and her syncopal episodes that she's been having. She was previously on Eliquis, but after having discussions with her doctors, the family decided that they wanted her off of Eliquis because of these mechanical falls that she was having. She did have one clinically significant CVA back in 2016, but thankfully those symptoms had resolved. So in our institution, we do typically do pre-procedural CT scans on all of our patients that are undergoing left atrial appendage evaluation. You can see the left atrial appendage here anatomy is not particularly hostile. The max diameter that we got on CAT scan was about 32 millimeters, and we have adequate depth here, not concerned about any type of bilobe structures like how we had during the prior session. Similarly on TE, you can see the structure of this left atrial appendage. We've got adequate depth here. It does have a large ostium. By 3D, the measurements of the ostium were about 26 by 32. That was the min and max. And we have more than adequate depth. The shallowest depth that we measured was 25 millimeters. So we proceeded with a Watchman. We had planned for a 35 millimeter Watchman device. You can see on the angiogram, again, a large appendage. There is some proximal trabeculations. We placed a 35 millimeter device. You can see on the angiogram that we don't have any leak there. Did an adequate tug test here. Device is stable. And so this device was deployed. We also did, obviously, look for leaks and compression, and that was fine. So I'm going to now ask our panel as well as the audience. This is a 79-year-old woman. She's had multiple mechanical falls, no history of bleeding though, so no hard contraindication for anticoagulation. She underwent a successful left atrial appendage occlusion with the Watchman device. What anticoagulation regimen would you recommend for her?
It's our practice. We switch everyone to DAPT at the time of implant, and that's across the board with all of our implants. And I know that we have an incidence of DRT of around 0.59%. We just actually looked at this for SKY in coming up with guidelines, and there's really little data to support the use of 6 weeks of oral anticoagulant therapy. When you look at the data, it really doesn't support that. So I think that the guidelines are going to reflect that in the new guidelines.
Okay. So in this situation, the patient.
I would give 6 weeks of Eliquis, DOAC monotherapy.
Okay.
I didn't think CHAD's VAS score on this patient.
It It was elevated. It was about, she had a stroke before. It was about 6.
Was she in sinus or
She was in atrial
AFib?
fibrillation.
So, I mean,
Yeah,
it's, you
she
know, there's a
was
lot of
permanent
surface
AFib.
area on that device. It's a large device. You know, hindsight's going to be 20/20. So we're going to see, you know, whether we made the right choice. But we tend, if patients don't have a history of bleeding, we tend to do DOAC monotherapy. But that's very important. You don't want to add aspirin to DOAC because then you're going to increase bleeding risk. So, yeah.
But here, you know, as an interventional cardiologist, there's no device that I place inside the heart to prevent device thrombosis by the use of anticoagulant medications. What you're trying to do is protect that device during which time endothelialization occurs.
Mm-hmm.
And if you go with a stent, if you're an ASD or a PFO closure device, if you're closing patent ductus arteriosus, whatever you close, you're going to be using antiplatelet medications. So this is the debate that we had amongst EP versus interventional, because in the EP realm, it's all anticoagulant. That's a very comfortable methodology for them.
No, correct. For our institution as well, we actually put DAP as well for 6 weeks. That's how we.
Yeah. And probably for the first Watchman trial is that the 6-week anticoagulation is probably it's a comparison because there was a comparison to warfarin at the other arm, so it may be partly carried over rather than truly insight.
All right. So in this situation, her course is a little bit complicated. We keep our patients overnight, and on the day right after her Watchman implantation, she developed a bowel obstruction. She ended up requiring surgery. And then the plan was to discharge to rehab. So now the mechanical fall issue, less of an issue because she was going to be under a monitored setting. We do prefer to do the 6 weeks of anticoagulation if possible. So we discharged her on Eliquis 2.5 twice a day. She did well at rehab. She came back for her 45-day imaging. This is what we got. So you can see here the Watchman device has thrombus behind it, but there's also a thrombus on the face of the device here. So what would the panel do here, knowing that she was discharged on low-dose Eliquis?
Did she meet the reduced dose indication with
No.
BMI and all that?
So she could have taken the full dose, but it was a discussion with the family. This was, post-surgery as well as discussion with the family. They had previously not wanted any anticoagulation. So the compromise that we had was low dose, again, because the data isn't super strong for full dose, for the anticoagulation. So we compromised on half dose, on the lower dose of Eliquis. But yes, there's no hard contraindication to full dose Eliquis.
Well, the good news is it's occluded. There's no leak. Bad news is it's a giant complex, material in there, presumably thrombus.
Mm-hmm.
It would be interesting to see on T how mobile that was. Is it like moving around like a slinky or what? But I think your option at this point is basically have to anticoagulate the patient fully.
And so if you're going to fully anticoagulate the patient, full dose Eliquis or warfarin therapy now? She's had a prior stroke, thrombus on the device, bulky.
Do a TE first, and then see how big it is, and the options, whether you wanna, do something about the thrombus. If it's located just like what the CT is just something we could do, like a mini angiovac or something, and then full dose, something like that, or I'd love to see the TE first.
I would do full dose.
Yeah,
Full dose.
Full dose, yeah.
Full dose Eliquis, so nobody for warfarin. No,
There's
okay.
no advantage.
And how many people would do additional imaging?
I don't think there's anything wrong in getting a TEE, but I think you have the information here based on the CT. And if you want to see mobility, you can acquire images across the entire phase and stack those images and play. I mean, you see a very irregular hypoattenuated lesion on the atrial side of the device, and that's a DRT.
But most of these that I have seen, the clots on the surface of a device, reminds me of a sort of like when unsavory people use a chewing gum and they stick it on a table. That's really like more like a solid mass sitting rather than, I have never seen it highly mobile, but I might be wrong.
Yeah, so I have seen case reports of, more pedunculated type of thrombus. This we thought, looked more like you said, a piece of gum stuck onto it. We didn't do any additional imaging. And so we had decided to do full dose Eliquis. What type of follow-up would you have for this patient? What type of follow-up imaging would you have for the patient? How long would you do the anticoagulation for?
because these patients have a tendency to recur in terms of DRT. There could be a small area you could have a small area on the face of that device that's unendothelialized or that is reluctant to endothelialize, and that would be a potential nidus for DRT in the future.
Yeah. There is something else in this patient other than device itself. There is some procoagulant state that it's not just, this is not commonly seen.
All right, so we did the full dose Eliquis. We decided to do 3-month follow-up CTA. So this is the thrombus at this point. So better than what it was before. Yeah. It's smaller, it's more laminar onto the face of the device. So what would the team do at this point as far as anticoagulation? Continue. Okay. Jason's side, he's thinking.
Well, it's dramatically improved. Yeah. Like I would say 90% of it is resolved. And now you just see a little bit, around the hub, which can be normal. I mean, that actually, what you're seeing is the metal frame, but the fabric actually, it goes to the tip of the hub. So that density around the hub may actually be beneath the fabric, So this actually looks pretty good to me. I'd like to spin it and see all the other views. I mean, I probably would feel comfortable going to DAPT at this point.
So 1 vote for DAPT.
I would also go to DAPT. I think this is a reassuring CT.
So 2 votes for DAPT, 3 votes for DAPT.
But also I think that the reformatting these images and looking en face of the whole surface, left atrial surface of the device would also might help us with determining the clot burden.
So Jason brought up a good point. So when we see this sometimes, we don't call it clot. We sometimes say that this is aggressive endothelialization. It could be clot behind the fabric. What if you got this image at your 45-day CTA? What if this was your initial image?
Even if the patient were on DAPT and I got a CT at 3 months post-DAPT and it looked like this, I probably wouldn't escalate. I would just continue the DAPT. It doesn't look high risk to me.
Okay. So we decided to continue on the Eliquis medication. She was tolerating it. What would be the interval imaging that you would do for this, if any?
Another 3 months.
Another 3 months? You would push it a little bit, okay. So we decided to do 6-month CTA, and we just got this imaging, and now we see this. So she's on full dose Eliquis still. What should we do? We just got this imaging back, so. We haven't made a decision yet. Hot off the presses.
The panel on the right still looks below the fabric cap. I'm a little more concerned about the panel on the left, and it looks to be a little bit more progression of this low attenuation on the atrial side of the device. I think if you're concerned, I would add antiplatelet therapy to this regimen. Is what I would do.
Okay. Other votes?
Would you consider other imaging? At
I
this
think
stage,
I'm
fair
just to see
by
whether or
now.
not to get further. Yeah.
I think just to, if there's uncertainty, I think at this stage, I think it's worth doing a TE.
Jason, you're thinking?
I think doing a TE at this point might make you feel better, but you're going to see something on there. There's no right answer at this point. I think the patients at high bleeding risk, you could continue Eliquis and then repeat imaging again at 12 months. But again, this volumetrically is not a ton, and it's pretty adherent. So, if the patient again they were on DAPT already, would I escalate to Eliquis? I'm not sure I would if the patient was otherwise doing well. So I think you could do a lot of things here.
Yeah. So, for us, it's going to be whether or not she's going to continue Eliquis or potentially move to warfarin therapy, but it's going to be discussion with the family at this point, just given that they were hesitant to have any anticoagulation before, and that we're moving forward with this. I do think TE could be reasonable because, again, the image on the right side still looks laminar on the surface, but whether or not, again, we're getting more of a mass-like clot that's forming on the left side, that's the question at this point. But we will do follow-up imaging in 3 months again.
Yeah, the image on the left, I mean, the frame looks very asymmetric in that cut. On the right side, it's kind of like a squared off, and on the right side, it really is, elliptical. So I wonder if it's just a strange slice on CT or there's some motion artifact maybe on that side too. Yeah. The device on the right looks very symmetrical, right?
Yeah.
On the left, it's very asymmetrical. So.
Yeah.
but that is the,
Yeah.
so I don't know if that's true or just some artifact.
I really think it's also, we should not make just judgment based on just these two images. I would really think that really better reformatting images, you can really see the entire surface of the device surrounding, because you don't know whether this is on the device or behind the device. So I would not make rush judgment just based on 2D images.
Okay.
I guess the safest thing to do would be to continue Eliquis and re-image at 12 months.
Yeah. So as far as key learning points for this case, even though the rates of device-related thrombus is low, it does happen, unfortunately, still with our current devices, and it's difficult to treat these patients once they've developed a device-related thrombus. And we need an algorithm for diagnosis of DRT, right? As we've kind of discussed, when you have that laminar appearance, is it clot? Is it going to be, is it just endothelialization, and then how do we treat these patients? And ultimately, it's going to be how do we minimize DRT risk with new devices? Thank you.
Great. That was a great case. I mean, that DRT remains the most challenging sequelae of this therapy. I mean, leaks can be managed in a variety of ways, but this is always a difficult conundrum. So we're going to move to our next speaker. I guess Dr. Nair was not able to make the trip. Nick, are you presenting in her stead?
I'm presenting in her stead.
Okay, wonderful. So we have Nick Amoroso from Medical University of South Carolina. Show us your case, please. Thank you.
I can promise to not be as good as Devi, but we have a case nonetheless. So this is a case of left atrial appendage thrombectomy, keeping with the theme, and occluder implant. So as we just discussed, the issue of left atrial appendage thrombus, either on the device or in the anatomy itself, is an issue that we are faced with regularly. It can be transient or persistent and is associated with elevated risk for thromboembolism. Current therapy recommendations is essentially systemic anticoagulation prior to device implant. Many patients, though, are at high risk for bleeding and poor candidates for anticoagulation, and thrombectomy may be a viable alternative if it could be performed safely and effectively. There's no device on the market approved for this, and we know the appendage anatomy is variable, delicate, and small flow volumes, presenting some technical challenges to such an approach. So our clinical case is that of a 75-year-old woman with atrial fibrillation, obviously, hypertension, diabetes, multiple GI bleeds. She presented with an MCA stroke, was treated with TPA, had hemorrhagic conversion. Subsequent follow-up imaging with MRI suggested that she also has a diagnosis of cerebral amyloid angiopathy. And if anybody's not familiar, it means quite fragile small vessels at elevated risk for intracranial hemorrhage with antiplatelet or anticoagulant therapies. She had had prior attempts with apixaban, and you can see here she had kind of an ongoing long course with us. She presented for appendage occluder evaluation, was seen to have a thrombus in the appendage. We said, we'll restart your anticoagulant temporarily and bring you back. Well, we did that, and she came back and still had a thrombus. And then we heparinized her inpatient for a while and switched her to a different anticoagulant. And we brought her back. Then she had another thrombus. And at this point, we said, you know what, you're just going to have to stay on the anticoagulant. I don't know what else to do. So we did that. Then she had another GI bleed. Then we said, all right, we're stuck between a rock and a hard place. You'll just live on aspirin. And so she went home on aspirin, and then a couple months later showed up in the ER with flank pain and thromboemboli to her kidneys. So now what do we do? Imaging. All right. So before we got to more, I'll skip to that. The CT showed there was still thrombus. So the question was, you know, this is kind of a unique circumstance with very high risk bleeding, very high risk for obviously thromboembolism. We've tried the best that we could with our available on-label therapies and failed. So SafeCross is a steerable catheter that has a balloon tip, and the dilator has an RF portion on the tip that allows you to do transeptal puncture. That's less relevant to this, but it comes in different curve sizes. You can see it very easily on both fluoroscopy as well as ultrasound. And the balloon tip provides you an atraumatic or a non-traumatic approach to intracardiac anatomy. We thought that we might be able to use this tool as a novel approach to make thrombectomy as safe as we could. So this is just an example, not this case, but you can see on fluoro, the balloon tip has a little bit of contrast in the inflation solution, so it's easily seen there. And you can approach the appendage easily to engage it, do injections through it, through the central lumen, etc. This is our case. So she presented, had this thrombus here in the mid and tip portion of the left atrial appendage, has a anatomy that's otherwise appropriate for an occluder device. We decided, just to be cautious, we would place a sentinel device for cerebral embolic protection. And we used our safe cross, the balloon tip there indicated by the green arrows, and simultaneously on fluoroscopy to perform our transeptal puncture. Once in the left atrium, we traded out for both a buddy wire and then a second support wire, which we then advanced our delivery sheath over so that we could do a rapid exchange, had our safe cross in the left atrium, and slowly approached the appendage with a no-touch technique, so to speak. So the balloon is partially inflated, smaller than what we knew the os was. We just very carefully, under our echo imaging, came up to the ostium of it so as to not disrupt the clot. We then inflated the balloon further so that now we're actually occluding the ostium of the appendage. And we set up this contraption. So what we did was we wanted to be able to aspirate from the safe cross sidearm, but small volume, so we also provided some saline through this pigtail catheter to basically create a lavage. And we used the pigtail catheter tip to helicopter around and also mechanically help stir up some of the clot to loosen it and make sure that we could aspirate as much volume as possible, as much thrombus as possible. And we did this for roughly 50 cc's of solution with our lavage. So that's just us little twerking around with our pigtail catheter and so we have the essentially cerebral embolic protection from the sentinel, but also from the balloon occlusion of the ostium with the safe cross balloon. So here we see that the thrombus is gone in the tip of the appendage, and we still have our balloon there. And no more thrombus, although I'll tell you there was a lot of smoke very quickly starting to reaccumulate. And so we used that buddy wire to rapidly exchange for our Watchman delivery system and deployed. Purposefully, we did not take an injection or angiogram there of the appendage, just again, if there was any reaccumulating thrombus to prevent, hopefully blowing that out into the circulation. So we've got a nice fit here at kind of our target landing zone. We did a tug test, there were no leaks, and we were satisfied with the result. She did go home on, we chose to do 2.5 of apixaban for her for 3 months, was what we landed on. Not sure if that's the right answer. I don't know what the right answer is for post-implant antithrombotics anymore. So my key learnings are there is a need for safe and effective left atrial appendage thrombectomy systems. Multi-purpose technologies like SafeCross may present new treatment opportunities, and thank you.
Nick, that was a really elegant case. I felt a little anxious when you were disturbing the appendage with the pigtail, I have to tell you. Having recovered from that, I have a few questions for you. So had you thought about just going to ball? Like, you could have used cerebral protection, but what about just going to ball and doing a no-touch technique with a Watchman device? I've done that in several applications, and not had any untoward events from that. And granted, the location of the thrombus was not ideal, but had you thought that?
Yeah, I think that that's rational. I think that there is a pretty reasonable chance that you will be able to implant the device without embolizing the clot. I don't think there's a guarantee to that, of course, and that's also assuming that you've got great imaging that allows you to see your landing zone, that your approach angle is very straightforward. This is not one where you're going to have to do a lot of manipulation and counterclock just to really gain depth and get up into the appendage, et cetera. So I think in cases where the anatomy is straightforward, the approach is straightforward, the imaging is excellent, that's probably just as safe as something like this. That's conjecture, obviously no data.
Beautiful case, Nick.
Thanks.
Like you said, it's the anatomy that has to be fitting with a safe cross. And in one of my experiences that if the anatomy is not like what you just showed, I had a case with basically when I moved to 135, it was the chicken wing. Mm-hmm. And so the thrombus was in the wing portion. Mm-hmm. And so we anticoagulate, we drawn back, and I think it's with Vivian and Bob Summers again, and came back and it was still there. And that's because of the low flow in that wing portion that even with oral anticoagulant, we warfarinized, it wasn't resolving. And so I remember Bob Summers, let's just put the no contact Watchman into that bulk of it and try not to disturb. But we did the sentinel. We did the sentinel, the cerebral protection, and like yourself, we discharged on, I think, a low dose anticoagulation. But you're right. I definitely there's a clinical need for LAA thrombectomy for difficult patients like this.
Yeah. I think if we can get away with a no-touch technique, device implant at times. However, if we're in a situation where we need to get away with it, then obviously there's an opportunity for us to have better solutions that are a little bit more predictable, adaptable to different anatomies and scenarios and situations.
Have you thought of other thrombectomy devices for this? And why do you choose the Safe Cross? Just curious.
Yeah, really just the adaptable balloon tip there was why I chose Safe Cross for this case. And it is steerable, so that gives you some range of motion to work with. Other people I know have done it with penumbra or with, thank you, angiovac. And somebody I think has done a case with some other aspiration catheter. Jason?
Yeah, it's amazing. I mean, so you came up with this idea, right? That's
I don't
impressive.
know if I want to take credit yet, but.
So how big does the Safe Cross balloon get? What's the diameter?
By the IFU, don't quote me on this, but I believe it goes up to like 2.2 centimeters or 25 millimeters. Now, in actuality, you can inflate it larger, but that's the labeled kind of sizing. There is rumor from East End Medical that they would have a version that is both a larger balloon or a wider range of sizes you could use with it, as well as a larger bore catheter.
And how did you ensure you're aspirating as much as you're infusing? Did you have kind of somebody's pushing, somebody's pulling?
We had two people going and just kind of trying to do like an equal rate of infusion and aspiration. You could actually, when you're on live echo, we could see kind of the volume of the appendage changing a little bit, so you could see if it was kind of like sucking down, that give a little bit more fluid. Yeah. But we also wanted to make sure we didn't just blast saline in there and then expanded so much that we lost our seal.
Just amazed that it all came out because you had a pigtail in a catheter, so that material had to be aspirated between the catheter and the
So the
pigtail
catheter was 5 French, and then the lumen of the Safe Cross is much like an Agilis, which is 8.5 French.
Okay,
so it's a fair amount of
quite a
space,
bit there.
Plenty of lumen for.
And did you try aspirating first without the
without the
egg
helicopter
beater
maneuver?
technique, or is that what you're calling it, egg beater technique?
Yeah, egg beater. That's a better description.
That is amazing.
We just kind of collectively thought that, all right, this is probably our best combination of techniques to
Right.
help ensure success, and we didn't feel like doing it multiple times.
I mean, it's high risk in the sense that if you kind of, disrupted it, but then it wasn't aspirating out, now you've got an appendage full of, basically pulverized clot.
True,
Which
true.
would be really
That is an important
a
point.
disaster.
In other discussions we've had about ways to even formally study this, we've talked about the thrombus character being an important element of this. Soft thrombus was clear here. I didn't show as many moving echo pictures, but it had that wispy kind of soft appearance, and on her serial imaging that we had lots of, then it was kind of different shapes. So it was clearly not a chronic, scarred down kind of thrombus.
And I know you've done a lot of amulet, and so the whole no touch with the amulet, going in the triangle mode or what have you. Was there enough room? Could you have done that?
We could have. That was we did this case at a time where I was not doing as much amulet,
okay.
so this was preceding my amulet experience.
Gotcha.
Yeah.
Other questions?
Thank you.
Okay, thank you.
All right, so it's moving on to our next challenging case. It's Imaging Saves the Day with Dr. Anjali Sharma.
All right. Thank you, everyone, for being here at 5 p.m. on a Friday evening. And thank you, Dr. Saraja, for the kind invite. And it gives me great pleasure to be presenting a case on a challenging left atrial appendage occlusion case where imaging saved the day. So no disclosures. So you have an 80-year-old male who was referred to our Center for Left Atrial Appendage Occlusion after a failed Watchman device implantation at an outside facility. He has a medical history significant for paroxysmal AFib, multiple GI bleeds requiring multiple blood transfusions in the past, congestive heart failure, hypertension, and coronary disease, giving him a high JADS2 score and a high thromboembolic risk. So before we dive into what was done at an outside facility, let's look at this appendage anatomy. So these are your 0, 90, 135, and your 45-degree views. And in your 135-degree view, which really is your caudal view equivalent, you appreciate that anterior superior chicken wing morphology. And the other thing to appreciate in all these views is most of your depth is lying in that anterior lobe. So these are your measurements for a Watchman Flex device. You're measuring at the level of the Saric, and your max dimension is 2.7 and a minimum of 2, and you have depth, but you see where they're measuring, it's all the way into that anterior lobe. These are your measurements for the amulet device. Your max for the landing zone is 2.7, and for the disc diameter is 3.34. So the shape of the left atrial appendage os is oval, and we did do an MPR on this one, and the measurements were pretty congruent with what we were getting with the 2D imaging. The intra-atrial septal anatomy is what made this case challenging. So you have lipomatous hypertrophy of the septum, and with a very narrow fossa ovalis, and really difficult to do biplane imaging and get the image that you want on the orthogonal view. So in short, you have an anterior chicken wing with a challenging septum, double trouble. So let's review what was done at outside facility before this patient arrived to our center. So these are the fluoroscopic images. The top left images, they're the appendograms. I want to pause here and get everyone's thoughts here as to what we thought was the issue here. As you can see, they were trying to deploy this Watchman device, and you have a very prominent shoulder on the mitral side.
Yeah, well, I mean, in the angiogram, you can see the anterior wing very wispy, right? It's coming up. So this sheath is actually pointed initially posterior, right? And you just can't make that turn. So, I mean, for a case like this, you want to be as inferior as possible. And so that's part of the challenge, right? Because your fossa is tiny in the middle. So you got to get hyper inferior for this to work, or you would use the true steer sheath.
That's correct. So, great comment. So I'm not sure why the number 3 image is not displaying correctly, but there was an image where they were trying to deploy the Watchman, and since the stick was not as inferior as you would have liked, they were kept getting pushed by the Coumadin ridge into that posterior lobe. So every time they tried deploying, it went into the posterior lobe. So clearly a very suboptimal result, something that we would not accept, and so. Oops.
So just because we can't see the upper right image, is that with the device of
deployment?
Okay.
Yes.
So it's canted?
It's canted. As you can see on the TEE, there's a very prominent shoulder. They tried a few sizes. They tried, I think, a 31 or a 27, and both did not work, obviously.
Can you guys move the live view away from the upper right? Maybe put it in the lower right?
Yeah.
Okay, so we can see, okay. So we're in that posterior lobe, and it's compressed and canted and not covering the anterior at all.
Yeah, 31 and 27. So I think regardless of what size device you use, I think that stick is really unforgiving in this case. And if I were to show you the TE images, they were really, really challenging at the facility, and I think the imager really struggled. It sounded like they were planning on doing a mid-posterior stick, but the actual transeptal puncture, based on what I could tell from the review, ended up a lot more superior than planned. So that was the challenge. So now the clinical challenge in this case is how do you accurately image the septum during the procedure? Where do you stick, and which device do you pick here?
I mean, this would be a great case for ICE-assisted transeptal, because you just can't see that inferior with, I mean, maybe Nadira can with MPR, but it's very hard to see that low on the septum. So this might be a good case for that, but you got to be very inferior.
I would say that also this is an endorsement for CT planning, because you really, to understand the anatomy, to understand the transeptal location, all that information is given with appropriate imaging up front rather than in the midst of this procedure. Right now you're stuck with a situation where you have a suboptimal transeptal puncture. Looking at, you might have to restick again. You hate to do that. You've got such momentum. You're committed to this strategy. It becomes difficult. Right. Whereas if you had the advanced imaging well in advance of this procedure, you would have maybe less difficulty approaching this.
So this was done at an outside facility, and so when we.
And I'd like to say also that, you know, with these steerable sheaths, we think, oh, well, we could do that, but with the steerable sheath. But I think even in a case like this, the steerable sheath will not overcome this. The transeptal puncture is still very, very important for the approach angle.
Any other comments? All right, so let's see what we did. So 3D MPR obviously came to the rescue. What we really tried to do was we went as inferior as possible on the stick, and we actually stuck mid to slight anterior on that septum. And if you see in the right-hand panel, I tried recreating your short axis view and the long axis view of the septum, and then based on that, we were able to, if you appreciate in the green plane, that's where you have that anterior stick, and in the red plane you have that inferior pointing stick. So this is the resolution. As you can see, the direction of the guide itself tells you that you're a lot more coaxial with the long axis of the device. We picked an AMOLED device for this case, a 28 millimeter. That's your lobe, your disc deployment, and we had a great result with this device. These are the corresponding TE images. Again, your lobe, your disc, and then 3D MPR clearly showing that you had a great seal, and we had no peri-device leak on this case. So I think the key learning for the operator and the team here is the transeptal puncture, most important part of the procedure, especially in challenging anatomies where you really need to optimize and use all that depth in the interior lobes, and especially chicken wing morphologies. And when this anatomy is tough, I think using all echo tools, including your ICE imaging, if needed, an MPR helps. In this case, I felt confident with the MPR imaging alone, and we were able to not use ice for this one. So.
Huge congratulations, Anjali. I mean, when we mentioned 3D MPR, I think Jason was looking at me smiling, and the first thing I said, yep, she was trained by us. Beautiful imaging, but definitely 3D MPR for the transeptal really is a game changer, not only for the appendage as well, but also for mitral clip. So really game changer in terms of locating where the true transeptal puncture is to get the height for your mitral clip. For this challenging image, you can see on the 3D very well visualized. So even if you biplane on the 2D as well, it's going to be really, really challenging on your orthogonal view. So you really align it to where exactly you want to be, and also the imaging as well into. And I guess the amulet, the device choice, the amulet was because of.
It just was an amulet day for our lab that day, and I think you could have done it without the device, and we had great support from amulet team that day, and we just went ahead and did it with them.
So I presume the outside hospital did not deploy the watchman.
They did not. Okay. Yeah. So they did not, and we saw this patient as an outpatient, and then referred.
And when you imaged, was there a residual iatrogenic ASD from the first transeptal?
Yeah, great question. I think that was one of my concerns, was whether they stuck the thick portion, given how superior that stick was. But apparently, I imaged 3 months later, and there was no ASD. I could not find that flow across the septum on this one.
So on the MPR, I didn't quite. Did you end up going through the thick part of the septum?
No, we did not.
You were still able to.
We were really. What we did was we recreated a short axis view based on the MPR planes, and based on that, you open up a little bit more,
right.
When MPR, and you see that there's a lot more interior than what you think there is, and there's a lot more inferior than what you think it is. So that's what helped us guide the transeptal.
Right, the bicable is misleading. There's a lot more inferior that you don't see. So MPR. I was just chuckling because it's referred from outside hospital for failed watchmen.
Yeah.
Often the watchman. I mean, you could definitely do this with watchmen as well.
Yeah.
I think it was more related to the transeptal. But
stick.
I think a lot of times politically, then we're sort of obligated to use the other device in a way. But. It was a great case. This is a really important issue with this procedure, and thank you for showing it.
Thank you.
Vivian, we are honored. We get you twice today. So you are presenting again another great case we're looking forward to. LAAC placed. What next?
Well,
I love the interactive presentation that you give. It's awesome.
Thank you. I'm honored. Thank you, Dr. Saraja, for inviting me to give these talks at this meeting. So this patient, 81-year-old gentleman, has a history of atrial fibrillation, obviously. CHADS VAS score of 6, HADS blood score was 5. And he was initially referred to us for left atrial appendage occlusion, of course. He was previously on anticoagulation, but this had to be stopped because he had a large lower GI bleed that required transfusions and hospitalization. After his anticoagulation was held, though, he did have a cerebellar stroke. You can see that he has a lot of pertinent cardiac comorbidities as well. Again, we did the CAT scan imaging. His anatomy in the in one view looked like he had enough depth, but you can see here on the top right image that his minimal depth was actually quite shallow at only 10 millimeters. His max diameter of the ostium of the left atrial appendage was about 24 millimeters. On T, you can see here that there's that chicken wing appearance, and again, in that 135 image on the bottom right corner, you can see that depth is really going to be a challenge for us. Nonetheless, we decided to attempt a watchman here, and you can see on our ariocaudal imaging that we do have limited depth, but we were able to place a watchman here. You can see that we have a waist on the watchman. It's at the level of the ostium, the face of the device, and you see that we have a good seal here. Here on TE imaging, you see that we did an aggressive tug here because we want to know at the time of the procedure if this is going to embolize, and knowing that depth was going to be our issue here. You can see that it's pulling on the wall of the left atrial appendage, and you can see on our 3D MPR imaging that the device looks well seated and that it's at the ostium of the left atrial appendage. There was no leak around the device. Our compression was about 12 to 19%. So we decided to leave this device. We all patted ourselves on the back. Great. We thought, we managed to overcome this challenge. Discharged on post-op day 1, but 2 days later, he collapsed at home. He tried to get up, and he had numbness and tingling and weakness in both of his lower extremities. So really a mechanical physical issue, not a syncopal issue. And he went to an outside hospital emergently. They did a CAT scan, and it demonstrated that our Watchman device is now in the distal aorta, occluding flow. We didn't have the CT imaging. We just transferred him over emergently, but you can see after we get our femoral axis here, just how sluggish that flow is going to the lower extremities. So important to know your devices as far as how you're going to potentially retrieve them. One of the big changes that happened from Watchman, the legacy device, to the Watchman Flex device is that they reduced that, the metal pin, right? So you can't grab onto the pin anymore. That surface is now flat. So what we needed was a Raptor device, which is a forceps device. That wasn't readily available to us in the cath lab at that moment. So while other team members were acquiring that device from another department within our hospital, we did have to stabilize the patient, right? This patient has ischemic bilateral lower extremities. We did access the left femoral artery as well. You can see on the left imaging here, it may be a little bit difficult, but the face of the device is actually pointed down. And so the fabric is in our way. So we obtained bilateral access to see how we would be able to approach this device in order to try and manipulate it so that we would be able to restore flow. We used multi-purpose catheters, angle glide wires. We were able to get along the side of the device and then through some of the stent struts. We had a 26 French Gore dry seal on the right side. And so what we're trying to do here is we're trying to create a loop. Because we don't have something that can pull on the device, we're trying to get in between two of the struts and create a loop and pull down, which is what you see on the left side. We have two multi-purpose catheters, and the snare is capturing one of the multi-purpose catheters in order to create that loop, just so that we can pull on the device, change the orientation, so that the face of the device isn't occluding all of the flow. And on the right side, again, we're trying different things while we're waiting for the Raptor device. And you can just get a sense here. This is a biotome, which we use in order to do our right heart cath biopsies. And you can see that the forceps are just too small. They don't have the strength to hold on to the struts of the Watchman device. This is a Raptor device. It's a larger forceps device, and it's got teeth on it so that it gives you more strength to pull down. We did manage to retrieve the other device, but we didn't hit Fluorostore soon enough because we were too excited by it. This is a different case, and you can see that we are able to grasp onto the struts of the Watchman device, and you can pull it into a larger sheath. So we were all very happy. We thought we were done. We retrieved the device, but we checked the lower pulses, which were good before when we had changed the orientation of the device. But now that we've retrieved the device, we checked the pulses distally. We've lost the pulses on the left lower extremity. So now we have to investigate what is going on. So we did aortograms. You can see that the ascending aorta is fine. The thoracic aorta is fine. But in the distal aorta, we now have a dissection there. From the anchors of the Watchman and presumably our manipulation when we were trying to adjust its position and then drag it out of the body. We had closed down the 26 French Gore dry seal. We had removed that, but we pushed down the pre-closes onto 6 French sheath on the right side. And you can see that that side is fine. But on the right image, you can see on our left femoral arterial axis, we now have embolization into the profunda artery. So we have a cutoff there. On our runoffs, you can see that the femoral artery is fine, but we have a or some type of embolization at the level of the popliteal, and so that's why we no longer have flow to our distal left lower extremity. We called upon our peripheral colleagues to assist us here, so we did do an up and over from the right side down the left leg. We were able to use our wires in order to cross that fairly easily, and then we used the penumbra in order to aspirate the thrombus at the level of the popliteal, and you can see that now we've restored flow down that leg. We then turned our attention proximally to that occluded profunda artery. We're able to use a run-through wire in order to cross that thrombus, and then again we used our aspiration catheter to aspirate that. This was a CAT scan that was done after the procedure during his hospitalization. You can see the ascending and thoracic aorta are fine. But as we get close to the level of the renal arteries, you're going to see a small dissection appear. So it's coming in there, and then it extends further down. Still there. And then here, the iliacs look like they're okay. So device embolization does happen, even though it's rare, even though we did our tug test. And it's important for you to understand your device, how to retrieve it afterwards, of what emergency equipment you have available to you. And if that emergency equipment isn't immediately available, just like in our case, you do have to deal with the emergency at hand, which in this case was the fact that we had critical limb ischemia, essentially. And so the other thing is that the device anchors, even though they're small, they can cause endovascular damage with all of your manipulations. So to keep that in mind, after you retrieve a device, not everything is done. You do have to evaluate to see if any other damage is present. Vascular surgery was involved in this patient as well, given those CAT scan findings, and just given its location, they said medical management was fine. Thank you.
Vivian, that was a great case. To me, it highlights a couple of things. Number one, the importance of having a cart designated for your structural procedures, whether you're doing TAVR, MitraClip, or even left atrial appendage closure, and having the appropriate equipment on that cart so that if a catastrophe occurs, you have all the readily available equipment right there. And that could be a balloon for a transeptal, it could be the Raptor device, which I would encourage everyone to have because of the performance characteristics of that device in comparison to other devices like a snare that we would use. It's just not something that you're going to be able to get. And the other thing is that I hope everybody was paying attention because the workup that occurred afterward with the angiographic images of the lower extremity were just very well done. And for those who don't do endovascular intervention, having that information with DSC acquisition imaging is very, very important to understand what to go after. And even if you're not an endovascular interventionalist, you can get these images while you call your colleague and put them one step ahead of the game. Well done.
Beautiful case, Vivian. What do you think happened, despite the tug test, the pass criteria in terms of the embolization? What you guys think? Your thought process of what actually happened.
Yeah, so we don't know for sure what had happened. One is that the device was quite compressed, so whether or not the anchors were not in a great orientation, whether or not our tug was too hard. And then also, if you look at the device, it does, the butt of the device or the feet of the device, it is still compressed, and so whether or not over time, this was one of our earlier cases with Watchman Flex, whether or not that radial force pushed it out, right? Because you still have that pointed end as opposed to a nice rounded back end.
Yeah, great case. I mean, so much to unpack. So you had an anterior wing, and the initial measurements that you got were about 20 millimeters was on your T, right? That was your max, and you put a 27 in. Right? It wasn't huge, right?
It wasn't huge. I think it was 22 was, yeah.
Not a lot of depth. It's a challenging net, so if you put a 24 in, maybe you wouldn't, what was unique about the final appearance of the device is that the body was very compressed, but the crown was relatively uncompressed. It's like a little mushroom, so you can see how, that would
It works its way out.
And then I guess the second question is, in terms of the aortic injury, do you think that happened from, my sense is maybe happened more with the attempts to retrieve the device as opposed to the device itself, like the myotome or something, get against it, because that's always very nerve-wracking trying to grab something imaging in the aorta.
Yeah.
Fluoroscopy, right? You'd like to have TE down there or something.
I'd like my imaging eyes to be able to go down there, please. So I think it was probably a combination. I don't think that it was, if we had the Raptor device, I think up front, and we just did a clean grab and pull into our dry seal, I think that that would be less likely to have caused injury. I think it was more when we were doing our snares and trying to turn the device, that probably that was what caused it, as opposed to like the biotome. Honestly, we didn't really try very much with the biotome. You know, that image was more just to show reference for everyone, just to see why that wouldn't work. We kind of put it in, we're like, that's not going to do anything.
So along the line, can I ask, so, well, you can hear me, it's fine. So,
Yes,
I don't do LA appendage, that's why I'm sitting here learning. I don't do Watchman or LA appendage, so I'm sitting here learning, but when you were trying to retrieve the aorta, is it safe to advance it up superiorly where there's more space? One, to maybe allow some perfusion to the distal extremity while that's happening, and two, maybe it's less likely to rub, because if you pull it inferiorly, each time you try to pull it inferiorly into a retrieval system, you're rubbing the device against a smaller vessel. I'm just asking, I don't know these devices that well, and if I were to be called in the middle of the night, would it be safe to advance or push it up higher when you're trying to retrieve it?
It depends on the orientation of the anchors, right, Paul? Because you have these anchors that are forward-facing in appendage anatomy, but invariably these things, as they go into the aorta, are going to tumble.
So which way is it safe?
Again,
I guess I need to
it depends on
look
the
at a picture.
What does...
Could be anchoring into the sides of the wall, so sometimes pushing it up, you can cause more tear up. Pushing it down.
So the anchors are almost like, they're kind of perpendicular to the face of the device. Or
Okay.
I guess they're perpendicular to the sides of the device. So in our case, with the face pointing down, the anchors are pointing out towards the aorta.
Yeah.
So in that situation, I wouldn't push up on it.
You would
but
not
just
push up.
Huh?
You would not push up.
Yeah,
I would not
either
push
way,
up.
you're probably going to end up scraping because, like you said, they're not really, you know, like facing one way or the other. They kind of just stick out. They're only 1.5 millimeters, but you know they're there. So and there's a lot of them. I forget the total number, 18.
There's like 2 rows of them also.
But as you're trying to spin it and get it into your retrieval sheath, I just wonder if you had just a little bit more room in a larger vessel. You don't think that would have made a difference?
If you can snare it, you can grab onto one of the struts and just pull it into your sheath, and that will collapse it, and it will also bring the anchors, as opposed to being out like this, in as you're pulling it down.
Yeah.
Because there's also the Ono basket, which people are using to retrieve in the left atrium, and that you kind of have to get over the device. And if the Watchman is kind of embedded,
Wedged.
it's going to be almost impossible to get the basket around
Yeah.
the ends of the device.
I mean, people have used the Watchman as an aortic filter.
Yep.
So if you first put it in, it's actually porous. I mean, that's why it's safe and blood goes through it. But you know, this embolized what, 2 weeks?
No, 2 days. It was 2 days
2
after.
days. So there's some at that point. There's some thrombosis, and the fabric's no longer probably porous at that point. But yeah, it's a tough situation.
Yeah, but even in the patients where they use the Watchman to help protect, they have slow flow. Like I've heard of other operators, you know, having to have like ECMO or something on standby in case they lose flow, even acutely.
Do you think the Ono basket, I don't know if you're familiar with it or not, but do you think the concept of the basket would be much safer to contain it, you know, to be used?
So I have no experience with the basket. I don't know if anybody else on the panel has utilized it.
We don't have it, we haven't used it, but we utilize devices too. So we want to know what we're going to do for the next device.
You still have to get the basket around the Watchman. So if the Watchman is opposed to the aortic wall, I think it would be hard to get the Ono around it. You'd still have to pull it in. You know,
I just have one comment. Once we have to retrieve something like this, and we didn't have the rupture, so we used vascular retrieval clap, and basically we just modify it. It has like that atraumatic part. We cut that and we use that. It worked really well. There's a review. We kind of like did the multi-center review. It looks like if you use this, or Raptors are better than snaring. It looks like snaring always like move it this, and this is where you get the injury. So I just have that comment here.
Yeah, I mean, I think the snaring is difficult. I think people try and put the snare around the waist of the device and things like that. That's not going to work. That's not going to give you enough strength to pull it in. We didn't think that we would be able to snare the device itself. It was really trying to create a loop just so that we can tug on it a bit, just so that the face wasn't pointing down, and it was off, oblique at least a little bit, so that it would restore some blood flow. Thank you.
Thank you. Okay, we're on to our last presentation. Stephen Filby from Cleveland, Ohio. My most difficult LAAC case.
There's two here.
Sorry, I separated them.
Thanks. Okay, let's finish off here. I don't know if this is going to be my most difficult case. I tried to pick some interesting cases. These are my disclosures. And this is usually the difficult case that I have, which is this chicken wing, where we end up doing this maneuver and sort of banking it off the wall there. But I thought, well, with steerable sheaths, this is going to be less interesting, I think, coming in the future. So I chose a case of a 76-year-old patient who had an EF of 50% and prior GI bleeding, but had undergone a convergent procedure, ablation and ligation with an atrial clip. And I don't know how many of your institutions routinely perform imaging after atrial clip. Our institution does, to their credit. And what they found is a significant residual pouch. The patient had still been on anticoagulant therapy, but was referred to see me for consideration of this pouch closure. And this is the CT imaging that was done for pre-procedural planning for that procedure. So we see a depth of 12.9 millimeters, not very deep, and we have an average diameter of 23.1 millimeters. Any thoughts about how and what and should we close this, and what sort of device would you think about?
How long after surgery were these images obtained?
The patient came to see me. This was done, the CT scan was done about 3 months after the ligation, the atrial clip.
Patient still anticoagulated.
Patient was still anticoagulated, and I would say tolerating reasonably well, but had a history of GI bleeding, has blood score 3, and very motivated to get off of anticoagulation. So thinking towards closure.
Yeah. I'm not sure what they clipped. Maybe just the tip of the left atrial appendage.
Well, I would say this is, with the atrial clip, it's a good procedure, I think. But if our surgeon's very diligent. This is the surgeon who did this case is very meticulous. But sometimes this is epicardial fat that they just cannot pick away. They just can't get to the ostium to put that clip down. And so you're left with a pouch. And this is what it looks like on angiography. Our plan was to start with a 31 millimeter Watchman Flex device, and didn't look like it sat that well. Certainly we see a shoulder there with, going to have a fabric seal even if it does have stability. Any thoughts about, should we abort here and maybe try a different device? Do we have the right platform? Doesn't look good. Yeah, it doesn't look good. We downsized. We went with a 27 millimeter device here. Same sort of thought process. I'm not happy with the tilt of that device. I'm trying to get coaxial with the neck of this, but just not able to really get a coaxial placement for this Watchman device. Call it a day.
What was the depth again that you had?
12.9. Yeah, and to that point, that's, I think, a very good point. I've done these with Amulet, and the difficulty is the the relative non-compliance of the amulet device in comparison to the Watchman. The Watchman is much more forgiving because it's much more of a fabric forward device as opposed to a nitinol forward device. So the coaxiality becomes very, very important here.
One crazy idea is you could try to wire the atrial clip. You know, like get a wire in between the two arms of the atrial clip, and then maybe, you know, try to access, you know, because there is residual appendage back there. And if you could get a catheter, and you could put a basket plug, you know, and put the disc behind the atrial clip or something like that, I think that'd be tough. But just thinking outside the box.
We were about to give up. We didn't feel like going smaller was going to have enough diameter, but yet we were depth limited. And our center is really, really leaning heavily on CT for pre-planning. We do all of our planning with CT.
What's interesting for discussion is even if you did close this, let's say they put the atrial clip in the right place, the LAAC trial would suggest that this patient should stay on anticoagulation forever. Like you know, if he's tolerating it, it's better for them to stay on. I mean, we don't have, you know, so that trial would suggest, I mean, that. So I guess it's interesting if you can convert this patient from a surgical closure to a percutaneous closure. Now you can invoke the percutaneous trials, and it would be safe to stop. But if just atrial clip alone, probably not.
Certainly not with a 12-millimeter pouch. I think that would be an unsuccessful left atrial appendage ligation by definition greater than 10 millimeters.
There are people with small appendage.
We downsized it, and I had given this patient so much contrast. I thought that there was a better dye shot that I had. I certainly did a lot of tug tests.
That device does not look compressed.
Doesn't look compressed, okay.
It looks like it came out of the box.
Came out of the box.
So we need solution out of the box.
And we tugged it some more, and tugged it even more. And this image on the left doesn't play. This is the mitral view. This is done under ice. And you can see that, and I expected this was going to be proud of the ostium. I knew this was not going to be a flush appendage closure, so we're going to be proud. The question is whether or not we have fabric apposition on appendage all the way around. And the right is our aortic view. On the left is a still of the mitral view. In both views, the device is proud of the ostium, but there seems to be contact, although it's not that compressed. And I'm not sure what our compression rate was. Look, this is a 24 device, and it was 2.1 across here. The panel on the right is our highly angulated view. That's the pulmonic view there. And that's where you see that mitral shoulder to the right of the device is the mitral shoulder, and it really is making contact right where the fabric ends. Should we keep this device? And this is, you know, going on to an hour case here, an hour and a half for a Watchman. We usually finish in about 20 minutes, so this is a long case for us. We could just retrieve it and call it a day. We didn't see a leak at that, and it's important, you know, we look at gap, not only gap, but we also look at color, but I lean heavily on gap because you don't always see, especially with the flex device where you have a lot of flow going through the device, you may not see a color leak, and that may not be true for the Flex Pro, but certainly this was a Flex. We really didn't appreciate very much leak there. If there might be just a tiny, tiny, tiny amount of leak at that mitral shoulder, we took the device. And what you're seeing is an NPR image that was done, or this is a CT scan and NPR imaging done about 2 months after the implant. So I'm just helicopter sweeping around in this en face view here, an axial plane, and just looking, you know, the long axis view. And what we see is a thrombosed left atrial appendage closure device without evidence of DRT. This is a closed appendage. All right, let me, if I have time, just go over a few key points. I mean, I think anatomy, understand the anatomy with CT, I think we've made that point today. And the other thing I think is, one of the things that I pointed out was I think the Watchman device is well suited because of the compliance and because of the anchor orientation. I think it has a nice niche for this sort of application, but this is something we're going to be seeing. AtrialClip is, with LAAOS 3, I think it's gaining more traction, especially at least in our surgical experience. If we have time for one bonus case, this is a really interesting case I just did. A 76-year-old patient had paroxysmal AFib, admitted with an inferior STEMI, massive GI bleed, cardiogenic shock, mechanical support. Patient was transfused with 9 units, and ultimately, prior to their discharge, of course, had recovery, but then underwent PCI of the right coronary artery with a drug-eluting stent. And then after all of this, some 2-3 months later, got sent for left atrial appendage closure because now the patient has indication for prolonged antiplatelet therapy and a massive GI bleed from anticoagulant therapy. And we did a Watchman device. Procedure seemed to be going pretty well, except for that when we placed we used a Baylis system, and we placed our Baylis wire in the left upper pulmonary vein, the patient became violently coughing. And if you don't know that, the phrenic nerve runs right across the left upper pulmonary vein, and sometimes you will encounter a patient that coughs a little bit, but this was like rib-splitting coughing. And this is a conscious sedation patient. We do our patients under conscious sedation, and we are meticulous about air management. Can you see these little bubbles here? Can you see those little bubbles? Do you guys see that? And if I have a pointer, there's no laser pointer. There are small air bubbles right there, which we initially didn't appreciate. We were thinking this is a great closure. We went ahead and deployed the device. You can see those air bubbles still if you pay attention. We released the device, and then if you look on the right side of that screen, you see a fluoroscopic Levine sign. That patient is having chest pain, ST segment elevation, started getting sick. Bradycardia, needing pharmacotherapy right now. And a lot of times, if you have air embolization, if you're doing an ASD or PFO closure and air somehow inadvertently gets into your system, it'll tend to go down the right coronary artery because it's an anterior vessel. And it also tends to go away. It just goes away within a few minutes, a tincture of time. This was not going away. And so we were obligated, of course, to shoot this patient's coronaries. And what you see is sort of a happy accident. This patient had a critical in-stent restenosis of that previously placed right coronary stent to the point where one sidewise bubble occluded the whole vessel, but in fact you see a column of air in the distal right coronary artery that was unable to be cleared because of that proximal lesion and that inflow problem. So we went ahead and performed balloon angioplasty, saw immediate angiographic resolution. We looked at the vessel with IVUS, and of course we demonstrated that there was severe ISR, and we went ahead and placed another drug-eluting stent there in treatment of that, and the patient went home the next day. And just to show you how careful you need to be, particularly with conscious sedation patients, keep in mind that anything coming in or coming out of that TUI has to be respected. You should really keep that closed at all times. This is something I preach to our fellows, and even still then, somehow air got entrained to the system with that patient's coughing. We actually create a little sleeve to put on our pigtail. When I put the pigtail into the TUI, I don't use a wire. I straighten it out with a sleeve that I have an off-label, use of a sheath there so that it just quickly can go into that TUI with minimal, and that's a wet-to-wet connection, just so you know, wet-to-wet connection. It's just to minimize any sort of equipment coming in and out, the amount of time, but still, even then, air got entrapped in the system and ended up embolizing, and fortunately for the patient, she did well. With that, I'm going to close, and I thank you very much. I appreciate you having me, Paul. We had, I think, a great meeting.
Well, another trick is we just use the back end of a J wire, the stiff end, and then you just have the wire sticking out, and you put that in, and then the pigtail goes in, and then you remove that. So.
Yeah, the key is to be attentive to that. I know of 2 mortalities across the United States where a large bolus of air was entrained and went up to the cerebral vasculature, and the patient coded and died.
All right, any questions, comments? Those were great cases. Thank you, Stephen, for closing out the session for us. So we'll adjourn. It's 5:30. Thanks, everyone, for being here, and thanks for the panel and all the presenters.